Going to look at diuretics. Those are chemicals that enhance urinary output. They include things like antidiuretic hormone inhibitors, alcohol, sodium reabsorption inhibitors, caffeine, drugs for hypertension, edema. There's things called loop diuretics that are inhibiting the creation of that salty medullary gradient, so they can inhibit the generation of urine concentration. There's also osmotic diuretics, which are substances not reabsorbed or reclaimed by the vasa recta or even the peritubular capillaries. So that means that that water that we want to reclaim for the concentration of urine remains in the urine. An example of an osmotic diuretic would be glucose in a diabetic patient. We next are going to look at clinical evaluation of kidney function, and urine can be examined for signs of disease. They actually used to taste urine to figure out if it indicated some type of pathogenesis. Luckily, they no longer really do that, but we still analyze urine as a great sign of any pathological disease or malfunction. So assessing renal function does require both a blood and urine examination, and we can learn a lot from both. Renal clearance is one example of a test that we can do to see kind of how well is stuff getting through the nephron. So renal clearance tests also can see how fast stuff gets through the nephron to determine glomerular filtration rate, or GFR. But they can also detect glomerular damage. We can see if stuff that's not supposed to get past the filtration membrane is getting past the filtration membrane. And we're also able to follow the progress or how bad renal disease is by using a renal clearance test. Now, renal clearance is the volume of plasma that kidneys clear of a particular substance in a given time. So it's basically how fast do they filter and then clear this filtered substance through the rest of the nephron. So renal clearance is C. Concentration of a substance in urine is U. V is the flow rate of urine formation in milliliters per minute, and P is the concentration of that same substance in the plasma. So this is the renal clearance equation. So if you see C, just make sure you know that that's the renal clearance rate. Inulin is a common plant polysaccharide that's used as a standard for renal clearance because it's freely filtered, meaning it moves from the glomerulus to the capsular space, but it shouldn't be reabsorbed or secreted. It should stay in the renal tubule. So after it's filtered into the capsular space, however long it takes for it to clear and end up in the urine is a really great indicator of glomerular filtration rate, which should be about 125 milliliters per minute. If it's lower than that, so C, or if renal clearance is lower than that, then that suggests that part of that substance got reabsorbed. If it's 0, that substance got completely reabsorbed into the blood. That's why none of it ended up in the filtrate or in the substances that were clearing the nephron. If it's equal to 125 milliliters per minute, or kind of normal GFR, that means we had no net reabsorption or secretion, which is what we see for inulin. And if it's greater than 125 milliliters per minute, we got some of that substance secreted somehow out of the peritubular capillaries, probably more than we were originally tested. Doesn't really happen with inulin. A homeostatic imbalance we want to mention is chronic renal disease. Chronic renal disease can be defined as glomerular filtration rate below 60 milliliters per minute, especially if that lasts for 3 months. So individuals with diabetes mellitus, hypertension, they're at risk for developing chronic renal disease. Renal failure is when glomerular filtration rate is less than 50 milliliters per minute. Now, this can cause uremia or things like ions, hormones, basically toxic molecules to accumulate in the blood because things are not properly being reabsorbed or secreted. It's generally treated with hemodialysis, which is basically like manual filtration in place of what your kidney's supposed to do. But hemodialysis is usually the short-term treatment, and the ultimate long-term treatment is a transplant with a new kidney. Next, let's look at some physical characteristics of urine. So it should be clear. We should not have cloudy urine. It should not be opaque. It should be clear. It'll have a slightly pale to deep yellow color. That's because of the pigment urochrome, which is a hemoglobin breakdown product. It's generally going to be more concentrated in urine of someone who's dehydrated, so it'll have a darker color or a deeper color. And we shouldn't really have an abnormal color to urine. Sometimes it's expected if you, for example, ingest a certain food, it could change the color of your urine. But if there's nothing that could have done that, abnormal colors like a smoky color or brown or pink urine are a little bit a cause for concern. It could be bile pigments or blood or drug breakdown products that are ending up in your urine. Now, the odor should be slightly aromatic when it's fresh, but it shouldn't smell like ammonia. The ammonia smell is going to be the decomposition of the solutes that are inside urine. That decomposition occurs by bacteria. But old standing urine, that will smell like ammonia, but it should only be slightly aromatic when fresh. It can be altered, so the smell can change. And usually that's because of some vegetables or something that we ate, maybe a drug that you're taking, a new prescription. So just be aware of that. But if there is a concerning odor for a long period of time, just talk to your doctor. The pH should be slightly acidic, but it actually can range from 4.5 to 8. But in general, the average is slightly acidic at a pH of about 6. Now, if you eat a primarily acidic diet or alkaline diet, that can change or modify the pH. But again, your kidneys are mainly going to be regulating your pH, so unless you're constantly eating protein or whole wheat, we're not going to see a major change regardless. Specific gravity is going to be the ratio of the density of a substance to the density of a standard, and so our standard is going to be water. Water has a specific gravity of about 1. That's where we're going to set it at. So the specific gravity of water is 1, which is pure water, meaning there's no solute or nothing dissolved in it. So if something's higher than 1, or if its specific gravity is higher than 1, it has some stuff dissolved in it. So a specific gravity for urine, or a respectable specific gravity for urine, is about 1.001 to 1.035. So there's going to be a little bit of stuff dissolved in urine, but it's mainly going to be water. So you see here it's 95% water and only 5% solutes. Some of the solutes are nitrogenous waste, urea, uric acid, creatinine. Those are breakdown products of, for example, amino acid breakdown or nucleic acid metabolism, or even creatine phosphate. Other things you might find in urine: sodium, potassium, phosphate, sulfate, calcium, magnesium, bicarbonate. So just different ions that we've talked about in some respect throughout this PowerPoint. If there's any abnormally high concentration of things like plasma proteins, or whole cells like a leukocyte or white blood cell, or bile pigments which are used for the emulsification of fats, this could indicate something's wrong with your filtration membrane or with your GI tract or other parts of your body. So it may indicate a pathology. Next, we're going to move and look at kind of the rest of your urinary system. Look at that urine transport from the kidneys via your ureter to urinary bladder. Look at the urinary bladder as a storage site. And finally, the elimination of urine via the urethra. So let's look at the ureters first. They're able to convey urine from the kidneys to the bladder. They are also retroperitoneal, like the kidneys. They enter the base of the bladder on their posterior wall. What we'll see is as bladder pressure increases, it's going to be able to put pressure on the distal ends of the ureters, and it closes them. So that pressure closes the ureters. So as the bladder pressure increases or urine fills up the bladder, that pressure is going to prevent backflow of urine. There are 3 layers to the ureter wall: the mucosa, which has an epithelial layer of transitional epithelium, a muscle layer called the muscularis, made up of smooth muscle. It's going to be able to contract in response to stretch, and it propels urine from the kidneys to the bladder using things like peristalsis. Then there's the adventitia, which is the outer layer, and it's an outer fibrous connective tissue that kind of helps position the ureters in place. So here's a cross-section of the ureter wall. We can see that when there's no urine flowing through the ureter, it folds up, kind of creates something similar to rugae in the stomach, but just not as well developed. But the lumen is folded, and the epithelium is transitional epithelium. It does have a connective lamina propria before we move into the muscularis, and like other organs in the abdominal pelvic cavity, it has a longitudinal and circular layer in its muscularis. The adventitia, again, is going to be fibrous connective tissue. We're calling it an adventitia and not a serosa because this is a retroperitoneal organ, or it sits behind the peritoneum. We want to look at a homeostatic imbalance called renal calculi, or the development of kidney stones, specifically in the renal pelvis. These renal calculi can move into the ureters, and if these large stones block the ureters and the ureter contracts on it, it causes a lot of pressure, a lot of pain. But what they are crystallized calcium. It could be crystallized magnesium or uric acid salts. Uric acid salts are commonly going to be associated with the condition of gout, but usually crystallized calcium, and they're just kind of kidney stones, hard rocks, and they may not cause any problems. They may stay in the kidney, they may not cause any pain, but they're usually due to chronic bacterial infection or urine retention or maybe increased calcium in the blood, changes, for example, maybe in pH. An increase in pH in the urine can definitely be kind of an indicator that you might have renal calculi, but not necessarily. They're easily treated by shockwave lithotripsy, which is non-invasive, no surgery really required. You go in, these shock waves are able to break apart the calculi, and then they'll be able to easily pass through the ureter without blocking it or causing that pressure and pain. Next, we want to look at the urinary bladder. The urinary bladder is a muscular sac for temporary storage of urine. Again, temporary. It is also retroperitoneal. Its pelvic floor is posterior to the pubic symphysis, so it sits behind that fibrocartilage that is the connection of the two pubic bones anteriorly. In males, the prostate is going to be inferior to the bladder neck, whereas in females, it's going to be anterior to the vagina and the uterus, the bladder will. There is a trigone, or a smooth triangular area in the urinary bladder, and it's just outlined by kind of three areas. There's the openings for the ureter and the urethra. Since there's two openings for the ureter, those are 2 points of the triangle, and the urethra is the other. That creates this trigone or smooth triangular area in the urinary bladder. But infections tend to persist in this region because it's close to that urethra, so bacteria can enter from the urethra, and in rare circumstances can enter from the ureter. There's different layers to the bladder wall. Also has a mucosa, like the ureter, also made up of transitional epithelial mucosa in that epithelial layer, like the mucosa of the ureter. Its muscle is called the thick detrusor muscle, and kind of like the stomach had 3 layers, the detrusor is also 3 layers of smooth muscle. And because the urinary bladder is also retroperitoneal, it has a fibrous adventitia. But we do find part of the peritoneum kind of on that superior surface of the urinary bladder. So that one part, I guess, technically has a serosa, but we'll say still it mainly has a fibrous adventitia. The urinary bladder actually has rugae. So when it's empty, these convolutions in the mucosa appear, the rugae, like the stomach. And when it expands, the rugae disappear. We see that the urinary bladder can actually rise up superiorly as it fills. And we see a lot of internal pressure as it fills up to about 500 milliliters. And it can be about 12 centimeter long when full. And if you really push it, your bladder, when full, can actually hold twice of that 500 milliliter volume. But I don't recommend it. It can burst if it's overdistended. That's why it's also not recommended for you to hold your urine. So here we can see again an x-ray or pyelogram of the kidneys. Here's the renal pelvis, ureter connecting the kidney to the urinary bladder, and the urethra is down here. We've yet to go through that one. So here's the structure of the urinary bladder in males. Here's that trigone region. So 2 ureter openings. They actually come in at that posterior wall near the base, so really close to this urethra, actually. And here's the opening of the urethra, so that's outlining the trigone. Here is the female urinary bladder. So we can already see that the urethra is going to be shorter in the female than the male, so more on that. But bladders pretty similar. They're going to be different in location because of the different reproductive organs, but the ureter is going to enter on that posterior wall near the base. The urethra is going to be a muscular tube that drains the urinary bladder. Its lining or epithelium is going to be transitional near the bladder and then stratified squamous near the external urethral orifice, but it's actually going to be kind of in the middle, mostly pseudostratified columnar epithelium. It has 2 sphincters, an internal and external urethral sphincter. The internal urethral sphincter is made up of smooth muscle. The external urethral sphincter is made up of skeletal muscle. So the internal urethral sphincter is under involuntary control, and the external urethral sphincter is under voluntary control. So you get to decide when the external urethral sphincter opens, whereas the internal urethral sphincter will open involuntarily. The female urethra is only 3 to 4 centimeters in length and tightly bound to the anterior vaginal wall, and its external urethral orifice is going to be anterior to the vaginal opening and posterior to the clitoris. So here we can see the female urethra, pretty short. Here is the external urethral sphincter, so it's in the pelvic floor, so it's made up of skeletal muscle, whereas the internal urethral sphincter will be in here, and that's going to be smooth muscle. So here is the external urethral orifice, and here is the internal urethral sphincter. The male urethra is going to carry both semen and urine, but at different times. There's 3 parts to the urethra. The male urethra is longer than the female urethra. The 3 parts to the male urethra are the prostatic urethra, intermediate part of the urethra, and the spongy urethra. So the spongy urethra passes through the penis. The intermediate urethra is between the prostatic and spongy urethra, and the prostatic urethra passes through the prostate. So here is the prostate. So here's the prostatic urethra. The membranous or intermembranous urethra is right there in the middle. It's intermediate. Passes through the pelvic floor. And then the rest of the urethra for the male passes through the penis. So this is going to be the spongy urethra because it's medial to spongy erectile tissue. We also want to mention another name for urination or voiding, which is micturition. And there are simultaneous events that occur so that micturition or urination can occur, and that's contraction of the detrusor of the bladder, opening of the internal and external urethral sphincter. Internal is going to be opened by autonomic nervous system stimulation. External is going to be opened by somatic nervous system stimulation. All three of those things have to occur in order for micturition to occur in an adult. In infants, reflexive urination occurs. So the distension of their bladder activates stretch receptors. That excites parasympathetic neurons. That's going to cause contraction of the detrusor in the urinary bladder, opening of the internal sphincter, and they don't yet have control over their external urethral sphincter. So its opening is going to be allowed upon this pressure occurring after internal urethral sphincter opening, and so we see its relaxation or opening occur in infants. They really don't get control, infants don't, of their external urethral sphincter until their pontine control centers in the pons of their brainstem mature at about the age of 2 to 3. The pontine storage center in the pons of the brainstem inhibits micturition, so it's also inhibiting those parasympathetic nerve fibers or pathways and able to excite the sympathetic and somatic efferent pathways. The pontine micturition center promotes micturition. Makes sense. Pontine micturition center is going to be focused on micturition or urination or voiding. And we're going to see that the urinary system is excited by the parasympathetic system and inhibiting the sympathetic system. That's actually going to allow micturition. Similar type of control we were talking about with the digestive system. So here's control of micturition. The bladder stretches. Stretch receptors send afferent impulses to the brain. There's also spinal reflexes, which increase parasympathetic activity, making it easier for the detrusor to contract and cause urination or micturition. If we are stimulating via the parasympathetic, we want to inhibit the sympathetic. Those signals that went to the brain act on higher brain centers, but can also activate the pontine micturition center in the pons of the brainstem or the pontine storage center, depending on what needs to happen. Do we need to open the external urethral sphincter yet? Maybe, maybe not. If we do, the pontine micturition center is going to promote micturition or urination by doing what we just talked about with the detrusor, but we're going to limit or regulate somatic motor nerve activity so that we can get that external urethral sphincter to open. We'll actually decrease somatic motor nerve activity so that decrease relaxes the external urethral sphincter, and that'll cause micturition. Now, if we're not ready to urinate, we got to find a bathroom, something like that. We'll actually activate neurons from the pontine storage center. They will decrease parasympathetic activity, increase sympathetic activity, and increase somatic motor nerve activity in order to tell the bladder and tell the urethra to halt and not open the external urethral sphincter. So that would inhibit micturition, but we could easily use this left side or the control of this left side as soon as we find a bathroom to open that external urethral sphincter and once again cause the detrusor to contract. A homeostatic imbalance we'll mention briefly is incontinence, which is usually from weakened pelvic muscles or kind of stress incontinence that puts pressure on the abdominal walls, and it can also force urine through the external sphincter. That would be stress incontinence, or overflow incontinence is when urine dribbles when the bladder overfills. So if you're just kind of holding urine too long for finding a bathroom, that can cause overflow incontinence. Urinary retention does happen usually after a treatment that uses anesthesia or because of hyperatrophy of the prostate in males, but it's just when the bladder is unable to expel urine. Usually this can be treated with catheterization. And that's going to be it for Part B of the urinary system.